name is Margot Field and I work for GPSA a few days a week at the moment. I was previously the CEO of GPSA before the fabulous Glenn took over the reins about 5 years ago. So I'm happy to be helping out tonight. I'd like to firstly give you a warm welcome and an especially warm welcome to our fantastic speaker, Dr. Ron Roth. Ron has been a supervisor for 28 years and a GP for about 33 years. He is from Hampton Park in the outer metro area of Melbourne. And one of his claims to fame is he's not had a registrar who hasn't passed the exams first time. So go you, Ron. This is also his pet topic. So awesome to have him along and doing that. I would really like to acknowledge the traditional owners of the lands on which this meeting is taking place and pay respects to the elders past, present and their families. So the learning goals tonight are what makes a consultation successful, what is the framework that underlies the effective and efficient consultation, and an approach to teaching and consulting skills that come with the science, and you GPs teach the art. So at this point, I'd like to hand over to Ron. So thank you, Ron.
Thank you, Margot. Okay, so I've been a GP supervisor for a long time, as Margot just said. As GP supervisors, I think our teaching falls into two broad categories. We teach content, the medical stuff that registrars need to know, and that's they usually come to our practices knowing a lot of stuff already. In my experience, they know more than this particular supervisor most of the time, and it's not really our job to teach them everything that in the textbook from acromegaly to Zollinger-Ellison syndrome, but it is our job to teach them how to apply the knowledge they've got to a general practice context, and to help them hone their knowledge base, to help them and to teach stuff that comes up contextually. So that's a topic for another discussion, for another day. That's not what I'm going to be talking about today. What I'm talking about today is the other thing that we do, which is teaching the process of general practice, and that they've had much less experience in. Yes, they've been in the hospitals, but I think that as registrars, we all know, as supervisors, we all know that the interactions with patients in hospitals and the interactions with patients in general practice are quite different for a variety of reasons, one of which is that we have a longitudinalness of care. We care for our patients over a long period, and I'm going to talk about the teaching of the process of the structure of consultations. If you like, yes, indeed, the art of general practice. So the question comes up of why would the registrar want to learn this stuff? Well, I would like to put it to you, and I'd like to make the case as the evening goes on, that a well-structured consultation is going to be an effective consultation, effective in achieving good health outcomes for our patients and identifying and addressing the issues that are important to the patients. It's nice to be efficient as well. My issue here is that all of us, registrars are not, do have difficulties with time management in consultations. Indeed, I think we all have difficulties with time management in consultations. I think a consultation that's well structured is a consultation that will run more smoothly and time efficiency will come. And I think that will become evidence as we go along as well. It's nice to be like, it's nice to like what you're doing, and it's nice to be liked. It's nice to have angst in consultations. It's nice for patient and doctor to feel respected, to feel listened to feel that the process has worked well for them. And that leads into the next thing. The registrars are often very keen to talk about this issue of not getting sued. What we know, and our medical indemnity insurers remind us from time to time, is that it's communication which is more likely to get us into trouble than the content stuff. And there's a couple of interesting studies that I often make reference to. There was in 1997 study in Toronto, Dr. Wendy Levinson. She recorded hundreds of consultations between doctor and patient, and about half of that group had been sued twice, and about half of that group had not been sued. And she was able to identify quite stark differences, quite interesting differences between the styles of those two groups of doctors. There's another study that, and I'm sorry, I can't actually tell you the hospital in the US. Where they looked at complaints to administration at a big hospital, and in of those consultation of those complaints, only 25% of those had a medical error, and when they looked at the medical errors, only 2% led to complaints. So communication is really important. Registrars are very keen to pass the exam. Yes, all of mine are passed. I think most, and I've had 100 by the way, registrars that is, but I think most registrars who go through the training program do well in the exam. Keep in mind that the exam is essentially role playing, and good consultation skills, a good structure is going to be of assistance to the registrars in passing the exam. So what I've done is I've developed a model to go through with my registrar. So I actually have a session in the, not straight away with my registrars. I usually like to watch them in action a little bit, sitting in with them. They definitely sit in with me, watching them role play and see where they're at and what they bring as natural instinct to the role. But at 4 to 6 weeks in, we sit down and I actually use a slideshow to go through a model of general practice for them. This, ladies and gentlemen, here is my model. You don't need to write all this down. We're going to go through each of these steps one by one by one. Before I go on, I just want to pay due deference to John Buckley, Wendy Francis, and Michael Greco. As I said, I've been doing supervising for a long time. In 1997, they brought out this workbook and a VHS video that went with it at the time. And it's a teaching module for interpersonal skills in general practice. I still use it with most of my registrars. I really like it, and you might like to seek it out. The reason I mention it is because I think that I've been quite influenced by a lot of the stuff that's in here. Some of my ideas influenced by or come from this work, and so I wanted to pay due deference to John and that team. I was, in fact, a Boy Scout in 1968, and be prepared. That's the first. This is the first step of my model. Be prepared. Now, this is all about what you do before the patient comes into your room. It's much more efficient to know what's going on, what the issues are, where your patient's at, if you have a read of the notes before the patient comes into the room. If you're trying to, you're not going to give undivided attention, both eyes and both ears to your patient, and you're not going to appear to be 100% concentrating on what the patient's saying, and indeed you're not going to be if you're fossicking through notes while they're talking and working out what were they here about last time and what did the test show. It's so much more efficient to read up what the last consult was, what the test results are, what you'd said last time. Embarrassing to say to patients, why have you come to see me today? And they say, because you rang me up yesterday and asked me to come. So it's good form to know what's going on beforehand. Patients have an expectation that you remember everything that they said at a consultation 6 weeks ago and 6 months ago, and it's so it's good to have had a look at the notes. I also like to make social notes in my record. Patients love it when you remember that the granddaughter was going to get married, and you can ask, how did the wedding go? And it's really important to remember that the dog died and all that sort of stuff for your for context's sake. So it's worth being prepared, not dwelling on the notes when the patient comes in. Give the patient your undivided attention. The icebreaker now, this if you like, is a little social chit chat. This is social and not business. This is a little bit of banter. This happens every single consultation. Check it out tomorrow. It will. It's the little bit of conversation that says, I'm friendly, I want you to be friendly, I'm checking you out, this is where we're at. It's all about establishing a contact. It's the common topics. These are topics that are safe topics. They can be discussed before the consulting room door closes. Typical topics are things like the weather or how poorly my football team is doing. So the patient wants you to know, hey, I'm happy. Hey, I want you to like me, and to check you out to see if you're grumpy or to see what you check you out as well. The information that you get from them is usually positive. It's not always positive, and so sometimes you get stuff like you'd be wanting to teach the manners to your reception staff or something like that, and then you've got an issue. But it's generally not rehearsed by any means, and it's not on medical topic. So the door closes and we sit the patient down, and the thing to ask the patient, what we want to know now is, why is the patient here? That's our job. We want to know what they're here for, and that's what we want to deal with for our consult. So we'll ask them, how may I help you today? My personal favourite is to say, what have you got for me today? There's various variations on the theme. What have we got on our agenda today? But the question not to ask is, how are you? Because that is possibly not why they're there. So if you say, how are you, you might well get, my knee is killing me and it's been killing me for 3 weeks and it's terrible and it's this and that, only to find out much later that they've actually come in for a Centrelink certificate or some other thing. So you want to know why they're there, and that's what you ask. So how may I help you today? What have you got for me today is much better than how are you? Rehearsed opener, you'd notice I've used a big font here. I should have used a bigger font. Rehearsed opener is a really important issue. If you go to the doctor, or if you're going to an interview, or you've got some important meeting coming up, what you do is you rehearse in the shower. You work out, what am I going to say and how am I going to say it to get the most impact. The way you figure it is, now what's going to happen here is the doctor won't listen to me for very long. He'll interrupt me pretty quickly. I better work out how I'm going to deliver the information I want him to hear in a way that will capture his attention and which will get my important points out early. And so you think, how am I going to do that? How am I going to present it so that I've got all the important data in there for he or she as soon as they get in the room? So they rehearse. And in the waiting room, they rehearse. And at the red traffic lights on the way in, they rehearse. So this is really important to them. It contains all the really important information. And it's really, really important that you listen to it. Okay? So unless all the information's in it, and unless your patient has a personality disorder, the rehearsed opener doesn't go longer than 45 seconds. Okay? A study in the UK looking at videotape consultations showed that the average GP interrupts their patient at 18 seconds. So let's not do that. Let's hear what they have to say, and make note. They've come in with an agenda item. They come in with stuff they want sorted out. So have a careful listen, know what it is. At this stage, be giving your undivided attention to the patient. That means looking at the patient, engaging the patient. So that's the thing to be doing, okay? Not your computer just yet. Next slide, Margot. Okay, so in fact, we're so keen to know all the information and all the things that they want. And we want them, we're so keen for them to be heard and felt heard that we'll lean forward and we'll say, anything else? Or even a little bit of silence implying, look, the floor is still yours. Feel free to chat some more. I've put the glasses there. If you've got glasses, they're a great advantage because you can minimally encourage by taking off your glasses and leaning forward, or even better still, you can put them back on. That always works. So encourage them to tell you more. Okay. I've got a thing too about your patient is your patient. So the patient is the one that you need to be talking to initially and addressing. And if it's a pediatric patient, that includes the pediatric patient. So if the patient's 3 years or more, I'm going to ask the patient why they've come. And now mum or dad has a rehearsed opener, and we're going to have to hear that. But it's great to address the patient, make the patient understand make the kid understand how this is going to work and that they're the center of attention. And what I say to dad or mum is, don't worry, I'm going to let you fill in all the gaps. Just to say that, let me have a chat to the little Johnny first. And then I do indeed turn to dad or mum and say, what hasn't Johnny told me? And then they go into their rehearsed opener, and of course you want to pick up on all their cues and their agenda items. Interpreters, particularly family interpreters, are a problem too. You want to make sure you're talking to your patient. The questions are directed to your patient, and then so look at your patient and let your translator translate. You're not having a consultation with the person who's doing the interpreting. So you make it clear to the interpreter that you're not wanting to hear what they have to say, that you're wanting to hear what the patient says to you. You actually want that translated. You're having a conversation with the patient. Elderly, depressed, and all that sort of thing. I had an uncomfortable I was watching a videotape of a consultation that my registrar, a particular registrar, not my current registrar, a particular registrar had done. And the patient was about 60 years old. She came in with her spouse, and she was very depressed. Psychomotor retardation sort of depression. And so what actually happened, the mistake that the registrar made, is very soon the registrar was directly asking questions of the husband, and we got to the point where the registrar was saying to the husband, I think we should put your wife on antidepressants. Now that was really uncomfortable for me. It had to be a discussion with the wife, with the patient. This is what I think is happening. This is, I think, what we're going to have to do. So your patient is your patient. Okay, so your patient has arrived and they've had their rehearsed opener and they've told you all the stuff, but maybe they haven't told you everything. And what you want to do is you want to find out now if there's going to be more stuff. Now is at the beginning of the consultation. We all have the experience of, I didn't mention those palpitations, 18 minutes into the consultation. So it's very, very reasonable to say to patients, is there anything else that you want to be discussing with me today before we move on? Is there any other issues that you've got for me? Okay. And there might be more issues. So find out now. So it's perfectly reasonable. The registrars are a bit scared to do that. Make sure they know. Perfectly reasonable. Ask, what else have you got? So the patient will have an agenda. What's very reasonable is you can have an agenda too. So for good health outcomes, for preventative health, it's very reasonable for you to identify issues yourself and run with your agenda as well as with those. You have a responsibility. So if you see that the fingers are nicotine stained, or the patient is depressed, or whatever it is, things are going to come up. You're going to run an agenda too. So consultations don't run with just the patient's agenda, they run with yours as well. And indeed, it might not be 2 agendas, it might be 6. The patient might have 4 and you might have 2. And the agendas don't have to be wrapped up and finished and dealt with in one consult, because there's a general practice. There's a longitudinalness of care. We can flag things for dealing with down the track. All right. So the patient has had a chat to you and explained what their issue is, and you've listened very carefully, and you're trying to work out what are their issues, what do I want to do, what do I have to come back to, where am I going with this. One of the things that holds consultations up, and when you watch videotape consults you see happen quite often. What often happens in consultations is that patients tell you things and then they tell you again. And they tell you again, and that's largely because they don't know that you've heard them. And one really important thing to do is say, I have heard you, this is what I've heard. So if you say, I've heard this, they're not going to tell you again because they know you've heard it. It's also a way of tidying things up. It's a way of getting it right because you won't get it 100% right. So you'll say, so you've had this cough for 3 days. No, I've had the cough for 6 weeks, but I've only had the phlegm for 3 days. Okay, so reflect, tidy it up and get it right. I've got a picture of a computer here on purpose. We at the beginning of the consult, we wanted to be really focused on the patient, looking at the patient. It's inefficient not to write notes during the course of a consultation. You need to, we don't want to be writing them all at the end. And if we leave it all to the end, we're going to forget all the nuances and half the details anyway. So it's a good time, you can reflect and type at the same time. In fact, it's almost saying to the patient, this is important, I'm writing it all down. It's you're typing and you're saying, you know, have you coughed any blood, blah, 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 blah. So type at this point, okay, get your notes right. Your patient's giving you all the information that they've got and all the issues that are concerning them, and you've identified their issues and you're thinking about your own agenda items. But now you need to fill in all the gaps. Now you need to ask all those specific questions that you've got. Registrars are used to this from the hospital setting as a sort of systems review type thing. It'll be a bit more focused in general practice, but now is the time to ask, have you travelled overseas? You know, have you had, has your weight increased? Has your weight decreased? Whatever all those relevant questions are, this is the time to ask. And this is where we're finishing off with our history taking. The less experienced registrar, of course, will go back into history taking later after exam and while they're summing up and wrapping. But we'd like to get all our history out of the way. Yes, indeed, history gives us 90% of the diagnosis. And examination often doesn't give us a lot. But let's say this, examination's really important. Examination tends to sometimes get neglected in general practice because we think we know what we're going to find. Examination is a really important thing in general practice for two very important reasons. Examination is important because it's diagnostic and because it's therapeutic. To discuss the first issue first. So yes, indeed, the patient might come in and say to you, look, my knee is really painful and I'm not coping with it at all. And you might know that this patient's got osteoarthritis and you might assume, well, this is their osteoarthritic knee and I just have to turn up the analgesia, or I have to do this, I have to do that, or it's time to refer them for a surgical opinion. But if you don't examine the knee, you don't know that it's not gout or that they haven't got a DVT or a septic knee. So occasionally you'll get a surprise. And occasionally, of course, examining will help you in your diagnostics. Yes, you do need to examine the patient to not miss stuff. The other thing, of course, is the patients want to be examined. They get reassurance out of being examined. They feel that they've been somehow the consultation is incomplete if you haven't examined them. They need the examination to go ahead. Now, I want to say that this stops at the examination being reassuring. This is not the laying on of hands for some sort of therapeutic benefit. It's not, you know, it's not for mystical therapeutics. It's just about making sure that the patient is reassured. If a patient comes in with chest pain, if you get out your stethoscope and listen to the precordium, you'll almost always hear nothing that's helpful. But if you have a patient who's got chest pain and you don't listen to the heart, then the patient's going to feel very much like you haven't examined them. By the way, you might lean on the chest and find out, of course, they've got costochondritis. So yes, you do need, for a diagnostic purpose, to do your examination. So examinations are diagnostic, examinations therapeutic. Examination is an important part of the consultation process. This is not a special COVID-19 slide. This slide is what you do after you examine your patients, and this is important too, because you now need thinking time, because the spotlight was on the patient at the beginning of things. What was their issue, and then they had a rehearsed opener and they presented that. Spotlight's going to move to you in a second. You're going to have to come up with the goods. You're going to have to come up with a really clever diagnosis and plan and all that sort of stuff. So use a little thinking time. It's also reasonable to write down your examination findings at this stage and have a think during that as well. And then you turn to the patient. It's time for the wrap. The wrap is the hardest part, particularly for a newer registrar. Hardest part for GPT-1, it gets a little easier as it goes along. The hardest part of the consultation. The wrap is where you say to your patient, this is what I think's going on. This is how I came to this conclusion. This is what I think we need to do. This is how I think we should proceed. So I'd like to think that the best wraps are short, sharp, and punchy. They need to be in language that makes sense to the patient. They need to be, so the patient has to understand what's going on. We have to cover the bases. We certainly have to try to be concise and stuff that they can remember and take home with them and have in their brain box. And what's very important at this stage is we need to be thinking back to when they first came in and when we had our rehearsed opener, because we need to know, well, what was the stuff what was the agenda stuff going on for this patient? What were they concerned about? So they may, for instance, be cancerophobic and think, I think I've got cancer. You might think, well, clearly it's not. But you have to come back at this point and say, I'm quite confident that this is not cancer because. So, of course, the other issue for the registrar at this point is they actually have to come up with a diagnosis, and that's not always easy to do, and it's not what we do often. We often come up with a differential diagnosis, and then we need to come up with a plan. We need to say, well, look, I'm not exactly sure where we're at, but I think that it's not this and it's not this, and it could be this and it could be this, and this is the way we're going to proceed. I think another thing that's reasonable in general practice, which might be a new concept for your registrars, a quote from me, quote, a non-diagnosis is a diagnosis, unquote. The issue is in general practice, sometimes it's just about reassuring the patient that no, you haven't got cancer, or no, it's not this, or it's not COVID-19, it's not whatever. So you don't always have to. It's not always cost-effective, time-effective, and necessary to get a diagnosis. Sometimes it's very reasonable just to say, we know that we're okay, or we know that we can wait, or I'm seeing no concerning features here. I'm comfortable to sit. You can contact me at any time. You can see me at any time. These are the things we have to be looking out for, but I'm happy to sit without a diagnosis here because there's nothing dangerous going on. I think that's perfectly reasonable too. So the wrap is really hard. I'd like and what you do is you develop, you hone your skills in this. You become better and better at it. You become better and better at it because you've been through scenarios before. You become better at the way you express yourself and understanding what the patients want to hear and what they don't want to hear. So practice is really important. Example is really important for the patients too. So give them the benefit. You are really experienced, and what registrars really like and really appreciate when you ask them what was good, what worked well and what doesn't, is sitting on you and your consults. Let them watch you live doing your wraps. If you do videotapes, video to your consults. So when I do videotaping, I videotape myself first, so that we can pull apart the model of consultation and we can look at the wraps. So lots of examples, lots of practice. So one of the ways to practice is role playing. It's great you don't need with role playing to necessarily do the whole long case thing. You can say, this was the history, this was the examination, let's go straight to the wrap. And practice a lot of scenarios, lots of wraps. If you're doing file reviews with your patients, which I do often, and I pull out at random. Let's have a look at patient number 4 from this morning. Tell me what went on, and then you can say to the to your registrar, okay, just deliver me the RAP. If the registrar comes to tute and says, I had a really difficult patient because of this and this and this, I'll often say, you be the patient, let me have a go at being the doctor, and we'll do it as a role play. So RAP is a skill. It gets better and better as they go along. Let them practice it. And certainly in terms of getting them ready for the exam, it's helpful too. Now, acceptance set is a concept from John Buckley. So, and I really like acceptance set as a concept. So you've chatted to your patient and you've said, this is what I think's going on. What you want is the patient to say yes and mean yes. That's what an acceptance set is. An acceptance set is when somebody says to you, yes, and that's what they actually mean. So you've delivered what you think's going on, what you think a patient should be doing, what you think's going to happen from here, what the likely course going forward of the condition is. It's going to get better in a week. This is going to happen. That's going to happen. What you want to see from your patient is that they're accepting what you say, that they're taking on board, that this is making sense to them, and that they're going to go home and follow through on this because it made sense to them and because they believe you. And so if they don't believe you, if you don't get an acceptance set, if you get what's called a false acceptance set, that doesn't work. Okay. I'll give you the example, a great example of a false acceptance set. We've all had this experience because lots of people say yes and they don't mean it. So if you go to a restaurant pre-COVID, when you were allowed to do that, if you go to a restaurant, and almost always what happens is the waiter comes to you, the waitress comes to you towards the end of the meal and said, "Did you enjoy your meal?" Now, unless you feel strongly that it was terrible, what most of you are going to do, I suspect, is say, "Yes, thank you, it was very nice," even if it was mediocre. Saying yes to the waiter doesn't mean yes. Occasionally you'll say, would you tell the waiter that, will you tell the chef please that the food was cold and the sauce was not spicy enough or too spicy? But you don't do that often. You usually just acquiesce. You don't want a false acceptance set. So you need to read what acceptance set is about. Is you looking at the patient, you're listening to the patient, you're looking at the facial expressions. So if the patient's giving you a false acceptance set, if you don't think, you need to rework your RAP a little bit. You need to say, you don't. I think I'm not quite getting that you're taking this on board. A favourite quote of mine is, "I'm not convinced that you're convinced." So I often say, "I'm not convinced you're convinced," but you seem unhappy with that. You seem, I don't think that's quite ringing true for you, or I think you've still got questions, haven't you? What's going on? Because you have to revisit it. The consult, it's not going to work. They're not going to take the concept home. They're not going to take your advice home and work on it if they haven't really felt that what you're saying is if that doesn't work for them, if they're not in agreement. So that's the acceptance set. Okay, so if you've got an acceptance set, and we can move on and we can safety net, and this is a concept most of you are reasonably familiar with too. So the safety net is all about, this is what I think's going on, but this is what might happen. These are the risks. This is what could happen. If this happens, I want you to do this. So, this is, if the pain gets worse overnight, I need you to go to the hospital, or if this develops, I need you to contact me, or this is why, in the scenario in which you'd call an ambulance, or whatever it is. These are the things to do if this doesn't work. This is to do. So safety netting, we all do it. We know what it is. It's fairly straightforward. Very important to safety net your patient. So we've actually worked our way through a structure of a consultation. And if you've followed these steps, I would put it to you that the consultation will come to a natural conclusion. We've started by wanting to know what's concerning the patient. We've asked all our questions. We've made sure we've dealt with all the issues. We've given them a level of reassurance. We've dealt with the issues that are at hand. We should just come to a conclusion. In fact, as a party trick, you should be able to, at the end of it all, say, is there anything else that I can help you with today? Registrar's a bit frightened to do that, but you know. So that's where we go. So that's that's my model of consultation. And so I take my registrars through a little talk, much the same as the one I've given you this evening, and then we look at it usually takes us, you know, I allow at least an hour for this, and I actually use a slideshow to bring up the headings and so forth, and then we make sure that we go into at the next tutorial into role plays, or I've got videotape vignettes that have got lots of mistakes in them, and we use those, and we work for the next few consultations on model, and we keep coming back to it. Because if you've got something like this, then it's discussing structure and discussing the process of general practice. We're good at teaching content. It's very easy to talk about the medications you need to treat diabetes, or how you approach the patient who's tired. But this, for many supervisors, is a nebulous thing. And this is a way of making teaching structure much less nebulous. All of a sudden, the registrar's got a concept of how a consult should flow, and we've got labels for things. So we can talk, we can look at the consults. I can sit in with a registrar, and when we're debriefing the consult afterwards, we can say, let's talk more about reflection, or let's talk more about the wrap, or how do you think tell me what was in the rehearsed opener, what were the cues for you? So, ladies and gentlemen, I put it to you that that's my model of consultation. That's worked for me. I'm not suggesting that you should use exactly my model. I'm not suggesting you should teach your registrars exactly the way I teach mine. But I'm always keen to share this, because it's, as Margot said, a bit of a pet thing for me, and I think it's an important thing for us to be teaching our registrars. It's not about what they know, because they know lots of stuff. It's how to do it, and that's what they're looking to us to help them with. That's what I hope we can help them with, and I hope that I've helped you help them maybe a bit more. Thanks, Margot.
Right. Well, thank you. Bravo, Ron. Somebody's put that in the chat box, and some really good points there. Absolutely. We have some questions that were sent in earlier, and there's a few questions in the chat box. So the first question I wanted to go to was one about the MBS item numbers. And if you read the patient's record before they come into the room, you can't technically bill for that time. So there's a question about that. Have you got a comment about that one first up?
I feel so strongly that it messes around with the consultation to not be able to start the consultation eyeballing the patient. What's your issue? Let's deal with your issue. It so messes that opportunity up, and it so much messes up the opportunity to go in really informed. So yes, I think that you probably, it's 2 to 3 minutes, and you're probably right. And I think if you're driven to decide whether your consult's going to be a B or a C, that's important to you. By all means, read the notes when you're there, but I think it does sabotage the consultation a little bit. That's my view.
Sure. I'll go on with some other questions. By the way, you're getting some lovely thank yous in the chat.
Good.
On.
Thank you.
This is a great question. Is the best consultation style simply one that suits one's personality as well as that of the patient? Or is there a preferred model out there among the many? But this really comes down to your own style, infusing that through a model, I think.
Yeah, look, what I say to my registrars is that I'm me, and I do, and please sit in and watch me do stuff and pick up stuff from what I do, and watch the other supervisors in the practice. And other doctors in our practice are usually generous enough to let the registrars sit in. And and I say, look, this is a structure that I want you to take the bits out of that work for you. You have to be you, but you can learn stuff. You can pick up pointers. You can say, this works for me. I can take this on board. And look, the example is that a registrar said to me, I just love that you say, when the patient comes in with the viral urti and you don't want to give them antibiotics, your phraseology is, look, I've got good news and bad news. The good news is you're going to get better. The bad news is nothing I do is going to make you get better quicker. And they borrowed that and they're going to take that. And so pick up stuff from other people, adapt it to you. You've got to be you. You've got to work with your own style. But I can't see there's any harm to say use structure and this is a tip on how it works. Most registrars take this stuff on board.
Right, fantastic. We have a question. There's two questions that are a little bit similar here. This one's from Simon. I have read that asking a patient whether there is something else rather than anything else is more likely to lead to the patient to identify the single issue of concern. Any comment on that?
A comment. It might be Miss Simon Morgan. Is that the Simon?
Yeah, of course, Simon. Well spotted.
Yeah, well spotted.
By the way.
Yeah. Yeah, I think he's probably right. I like that. I'll take that on board. Yeah, something rather than anything. Yeah. Yep. I think he's right. I think that's valid. Yeah, thank you. And I'll adjust what I say next time.
And with the something else or anything else question, the fear that's in registrars is because they don't know how to wrap around that next set of questions. Well, could you explain how you help them with that bit?
Yeah, absolutely. So it's so much better to know all the stuff early than be lumbered with it late. That's a much worse scenario to find out late. The issue is that you often get a lot of stuff and it's too much stuff to fit into a single consultation. So from the rehearsed opener, you know why they came today. Yes, there might be other things that they, given the opportunity, yes, well, I've got you and I've got myself at last a general practitioner who's interested in me and the whole me and all my stuff. And yes, seeing as you asked, let me tell you that I'm worried about my weight management, and let me tell you that I'm worried about the getting rid of the tinea between my toes. So what I tell my registrars is that let's identify all the stuff and let's develop approaches, strategies, and I think strategies is a better word than tactics. Let's develop strategies of how you deal with it when there's lots of stuff. And the way to deal with it, of course, is to say, and reflect on it and say, I've heard all of this. Today we're going to do this, this, and this, but let me write down that we've got to get this done as well. And I even go so far as to say, no, I don't think I'm going to get the PAP test done today, or I'd really want to address this whole issue about the interplay of you and your in-laws or whatever it is, and I'm writing it all down, but can I set aside a specific time later this week or next week so we can deal with the stuff we don't get today? So actually, and I've got a strategy too that I often say to patients, look, I definitely want to do this. So I reflect on, I'm doing my reflect now, I want to do this. I'm going to sort this today. And let me, and I actually book the appointment. What works for you? When's good for you? And that says to the patient, hey, this is important. And he really does want to follow through. And he's not fobbing me off and say, look, let's do it next time. Because that sounds like he doesn't really want to deal with this. We'll do that next time. Doesn't work. To say, can I set aside a time? And just I go on my computer and say, what day? And I'm usually booked out, and I say, I can't do that, and can I do this? And we can do it, and let's do it. And that's, and I'll, if I need 3 consults, 4 consults, so be it. That's my strategy, and that's what I teach my registrars to do.
Fantastic. Okay. We've got heaps of questions, so thank you.
It's as good, isn't it, that we've got heaps of questions?
Yeah. So here's another question from Mark. I'm interested in the acceptance set. How might you approach the I don't know what's wrong, you are the doctor?
That's good, isn't it? Okay, I might role play this a bit. You're right, I am the doctor and I have to know the answers here. And what I'm trying to do now is work this out, because I haven't quite worked this out completely yet. I think I'm going to need to do a couple of tests, and I think I'm going to need to have a little thinking time. And I am going to put my mind to this, and I'm even going to ask a couple of colleagues, and I'm going to meet with you again in 2 days' time. Let's do these tests. I think we are going to get to the bottom of this. If we don't get to the bottom of this, then we'll talk about what our next strategy would be.
Terrific. Fantastic. So you just take it full on. Wonderful. Here's another question. What are the tips for increasing communication for doctors who have an accent or English isn't their first language?
Okay.
Around that.
Yeah, look, I think that lots of doctors have accents and so forth, and we just need to slow their speech down and so forth. So one of the role plays is great, and I use them a lot. I want to talk about videotaping for a second, and videotaping is really good because they can, with videotaping, then the doctor is getting a second chance at looking at the patient and seeing what the patient's understanding, what the patient is not. Videotaping is probably the single most useful teaching tool, and we're not using it much now for the reason I think people know in Victoria, certainly about the fact that it has to constitute part of the medical record if you record, and therefore you have to keep it. And some registrars and some supervisors are unhappy to think that their recording's still going to be there in 20 years, and it's a space issue. It's a digital space issue. I love videotaping. For 15 years of my supervising, I did loads of videotaping, and now I do it less. But videotaping is fantastic in this sort of situation, because the whole issue for the registrar who has the accent or who has any other reason why the patient's not understanding or face and has a discomfort is the registrar can watch himself. And the registrar can learn, without you having to say anything, what doesn't work, where the patient gets mixed up, sees when he or she slows down, and I can stop the video and say, where do you think, how could have you done that better? We're going to have to, and we can face up to the fact there might be an accent. Hey, there's an accent, so let's slow it down. If the accent is an Iraqi accent, I'll say it. Now, if I was consulting in Iraq, nobody would understand a word I'm saying. Just as an aside, by the way, what I have realised in the last 2 weeks is I've been wearing a mask for consulting during the pandemic, and I had no idea how much my patients lip read me, because all of a sudden nobody's hearing anything I say, because they're not lip reading me and they're not seeing the full extent of my facial expression. That's really interesting. So yeah, videotaping is a good way, and a respectful discussion with the registrar concerned, and work on it, and look at it 4 weeks later and 8 weeks later and say, is it working better? What can we do?
Terrific. A few more questions here. Why do some registrars always finish history taking too early? Or is it just that that's what I'm observing? And am I the same? And the other part to this is, if it's anxiety and worry, which is some underlying anxiety, which means that registrars cut in, is your teaching directed to getting them to stay calm? Do you address it from the underneath issue? So there's two parts. Why do they do it? And if it's anxiety, do you tackle that bit straight on?
Yeah, look, I think there's a couple of reasons they do it. One is, yes, you are anxious. The registrars are anxious and they want it to keep rolling, and I think their consults look different when you're sitting in than when you're not. So there is a level of that. There's a level of let's get on with it. Time is of the essence. So if I interrupt now and ask a specific question, that'll speed stuff up, and in fact, it slows stuff down. So you need to just look at consults and slow it down, and what worked and what didn't, and this is what I'm observing. And so, having been through the model, I'll say to registrars, what point did you interrupt? I'd say to registrars, tell me about what minimal encourages you used. Tell me what you did to squeeze the extra juice out of the lemon to make sure you'd heard it all. So I asked them about that. I've introduced the concepts by giving all these things labels and headings so that they understand what the concepts are. So you can go and visit those things. And so role-playing and sitting in on consults, and even better still, videotaping is really good. And it's really powerful too, if you're videotaping, to videotape yourself and be really critical of yourself and say, look, I didn't do that, and I missed that cue, and that works too.
Yeah, terrific. There's nothing like a video to enable you to see what your facial expressions are doing and whether they match up to what you think they're doing, which is quite surprising.
And you don't realise until you watch the video, about, is the patient understanding what you're saying, seeing that facial expression, and get much more, you'll revisit, is the acceptance set there? But you'll also see how many times you've repeated yourself, how many times you've said and ah, all that sort of stuff. Yeah.
Okay. Look, we've got about another 10 messages. Some of them are lovely comments, and thank you. And I'm just going through and picking the best ones, and we will do our best to get through all of them. So thank you, everybody.
Thank you, everybody.
Yeah. Do you know the percentage, Ron, of patients who rehearse for the opener compared to those that don't?
I don't know the percentage, but my feeling is that it's the majority. And I think it's the big majority. I think most patients are working out what they want to say. If it's a follow-up, if the patients met you many times before, maybe there'll be less of it. But no, I think in most cases, if I'm going to a meeting, if I'm seeing my doctor, my GP, if I'm got anything going on, I rehearse. Not at a conscious level necessarily, but I think I do. And I think I do it in the shower the most, just by the way.
Okay. Here's another. There's a couple of comments here.
I think, just by the way, that the first 3 minutes of today's presentation, I probably did in the shower a couple of times this morning.
Well, there you go. That's why. You started very strong, Ron, and you're still continuing. So thank you.
That's right.
A few more good comments here. It might also be helpful to teach registrars that moments of contemplation and silence can add a lot to a good consultation.
I absolutely agree with that. I'd really like a little bit of silence after they've delivered their rehearsed opener to say the floor is still yours. I like a bit of silence to see that we're all thinking things through. And there's particularly a silence for me often when I'm just finished the examination, washing my hands, sitting down, writing a note or two. And I'll even say to the patients, I just want to get my thoughts together. Can I write a couple of things down? And then I finish with my computer, because the wrap is another of those things where you turn to them, you lean forward, maybe the glasses come off or go on, because this is the important stuff now, and let's do this. You've got my full attention for this.
Terrific. It's a lot about your body language as well as those little subtle cues. Another couple of comments.
And can you see, therefore, that if you're reading, if you don't do the pre-prepared stuff, you are going to, early in the consultation, be leaning to the notes, putting 25% of your time into checking when that last test was done. And it's just so much better to be focusing on the patient. Yeah.
Simon's made a great suggestion in the reflection part. Statements, I presume this is what you mean, Simon. I hear your ideas. I feel that I understand your concerns. Am I right? I want to address your expectations. And I think that reassuring and that clarification of role is very helpful. So that's a good point.
I think that's a really good comment and a really good suggestion. And this is, if you like, people bringing their own stuff. So I'm saying, look, here's a structure, here's a framework, because consultations without structure go all over the show, and they're not efficient, and they're not time efficient. But don't slavishly work with my model. Here is a model, but and bring your own stuff to it, and that approach to the patient who's a little unsure, and that approach to reassurance is really good. I really like it.
Yeah, terrific.
That suggestion.
Okay. We've got a couple more questions. Any updates on ECT visits or on proper consultation strategies? I'm not sure that question makes sense.
Well, can I just say about ECTVs that the ECTVs during the pandemic were on hold for a bit, and I've just heard today that they have to go ahead. And I have my current registrar's having an ECTV on Monday, and the instructions are that you will have your laptop open, and it will be, and I will be zooming in, and we'll have the patient's consent, and I will be in the consultation on Zoom and doing it that way. So they are, my understanding is as of this week or next week, they're back on track, and they're going to, I don't know how well that will work, but that's what's going to happen with ECTVs. So, and they are live connections, they're not recordings, so they don't need to be kept. So that's the other issue with regard to that, just in reference to what we're saying about having to keep if we tape consults. So ECTVs are back up and running is my understanding.
Great, thank you.
And I would like to think that that the medical educators who are doing ECTVs will have strategies around, you know, because they're looking too at content and process, and I'd like to think that they've got strategies to be discussing aspects of the process with the registrar, debriefing and saying this didn't work because, or this worked well because, or you did really well with this and do more of that. Yeah, so they need to go. It needs to be not nebulous for supervisors, for everybody. There needs to be structure. There needs to be labels. There needs to be understanding of how a consult should flow.
Terrific. Okay, a couple more questions, and thank you. If you want to hang on for a few more minutes, everybody, there's a few good questions coming up. How do you manage the patient who's left the room and wants to come back to you, but you already have another patient in the room? Is there a quick way around that?
Well, my strategy is, could you please let them know I'm happy to chat, but I'm probably going to be 10, 15 minutes, and I overestimate rather than underestimate. If they're happy to take a seat in the waiting room, you're happy to send me an email so I don't forget. I'm happy to have that extra chat.
Terrific. Fantastic. We've got another comment, and I think this is absolutely true. Silence is often good when an adolescent is sullenly silent. So it's a matching tip. Yeah.
That's good.
Yeah. We've got some more here. Yeah, there's a comment here that's GP Synergy is running training for remote CTV at the same time as this webinar. There you go. Now, here's an important question. How do you tailor the teaching to registrars at different levels? So this is an awesome presentation. What do you do with a different, you know, registrars coming in at different times when you take them?
Absolutely. So I have GPT 1s, 2s, 3s and 4s in my practice. So and I start every single tutorial with what is there stuff you want to talk about, and I'll put off whatever I have planned to the next one if need be. So I take lots of feedback from registrars, and I try to match the tutes with what they want to do. And I see where they're at. And I think this talk works for registrars at every level, but they take different things out of it at different levels. So I think it's eye-opening and almost survival skill for a GPT-1. I think there's stuff I can take out of this. This is helpful for me when it's GPT-3. Because there's a version of this talk available in my regional training, it's in my region. Some of them have already seen it before they even come to the practice, so they know a bit about it.
Yeah, terrific. Okay. Tips to help registrars. I think we'll make this the last question. Tips to help registrars with time management when you are very good at it yourself.
Okay, so I'm not very good at it myself, so this question doesn't apply. No, I think I am good at it. I will make the case that good structure, flow makes sense. I think I've presented today quite a number of things that make consultations more time efficient. One of them is making sure that you know all the stuff that the patient wants to deal with early on so that you can structure your consult. So making sure you get all the information. Another is that you reflect and you say, I've heard you. You don't need to tell me again and again and again, because this is the issue, this is the issue. So they know you've heard. They're not running a structure that's got flow. And the other thing is flagging things. So I think it's useful to flag things and say, this is something we're going to discuss. This is something we're not going to let go, but we're not necessarily going to do it today. It's written down. We've got a plan for this. All of these are strategies that help with time management. And the last thing that I'd say that helps with time management, and it is a skill that you get better at, is that, again, I say, what doesn't always happen for every registrar, and which is so valuable, is the registrar sitting in and watching the supervisors do their stuff. So if you're a good time manager, let the registrars see it happen. Let them sit and see your skills that you've honed. You know, as I've been a GP for 33 years. I'm starting to get the hang of it. So that being the case, let my registrars sit in, and let's pace it. If that's happening, make sure you've got time to talk about the consult and what was good and what they took out of it, as part of your tutorial. So, and it's perfectly legitimate shoot, a very valuable shoot. If you've got an hour and a half, just schedule in for yourself or the registrar to see one patient or two patients. Have time to see have talking time about that, and have talking time for other stuff. Really, registrars like that sort of stuff, and I like that sort of stuff, and it mixes it around a lot.
Yeah. There's one other thing here. Yeah, a great comment here from one of the participants. I find that my registrars are much more time efficient as they don't know the patients, so are much less likely to have the pleasant small talk at the start. So basically what's being said here is that they don't get stuck into too many details.
So I disagree. And I disagree on a couple of grounds. We've got the huge advantage of knowing our patients, having heard whole the story before and taking up where we left off. The poor registrar who hasn't met the patient before doesn't know the background story, doesn't know the history, is starting again. It's like a long case, it's new. We're just one bit in a journey. So that's a difference. And I go back to what I said before. It's really useful to write social notes and to bring up at some stage, how are you enjoying having the new puppy in the house? So that's respectful of the patient. There is some banter, some discussion, but you can keep it reasonably controlled. Yes, some patients love to chat and chat and chat. When you read John Buckley's book, if you do, and there's a fantastic section called Roadblocks to a good consultation, and that's all the things that you shouldn't do with active listening and with respectful listening of your patients. That's all the things that block a discussion from going ahead. And they're things like praising the patients and using logic to sort of diversion tactics and other things. So have a read of this section. I think it comes out of a book that was written in, it's not actually John Buckley's original stuff. I think it comes out of a book by a guy called Thomas Gordon in 1980. At these 12 roadblocks. But I must admit that occasionally I'll use a roadblock if that's what I need to do. I don't do that very often. We talked about unless your patient has a personality disorder, they'll be finished their rehearsed open in 45 seconds. I use the roadblock strategies for my patients with the personality disorder sometimes.
Great, thank you. So thank you to you, Ron, for your absolute gold, and your depth of knowledge is just awesome. I think the chat room's been solid with lots of fantastic comments and questions, and clearly this has been really valuable. I'd like to let all the participants know that we really love your feedback, and an evaluation will be going out directly following this webinar. That really helps us as an organisation. Also, very importantly, next Tuesday night, the 12th of May, we have another esteemed, fantastic presenter in Dr. Simon Morgan, who is assessing a registrar doing telehealth. So that's next Tuesday night at 8 p.m. We've had such a fantastic series of webinars around telehealth, and we really are hoping that this is beneficial to everyone. So I think we're just going to finish here by saying thanks, big thank you again. Hooray, hooray to you, Ron, and to everyone who's listened in and given up their night to learn some things. Just letting you know that GPSA is supported by funding from the Australian government under the Australian General Practice Training Program. Woohoo! We're all here because of that. Thank you so much, and we look forward to meeting up with you again. Thanks a lot. Bye, everybody.